and title use of universal anti-hemorrhage drugs in obstetric and gynecology. دكتور أيمن أبو النور موجود.
اوكي بسم الله الرحمن الرحيم. طبعا يشرفني اكون في وسطكم كده عشان صوتي رايح فهقرب المايك على قد ما نقدر. نشكر تشير بيرسون كده. هنتكلم على general anti-hemorrhage agents and OBGYN ده sponsored بأبوت عشان الناس تبقى عارفة full disclosure كده. دلوقتي الجنرال anti-hemorrhage agents ده هنتكلم عن Tranexamic acid blocks ان البلازمينوجين يتحول لاكتيف بلازمين. احنا كلنا عارفين اللي بيحصل ايه في الكواجوليشن. coagulation system بيحصل لها initiation, it initiates, then it forms a clot. This clot blocks the bleeding. If the clot is unstable or dissolved too rapidly, then we reinitiate the bleeding. And then these fibrin degradation products, which are formed by dissolution of the clot, cause more and more bleeding. Then we enter into a vicious cycle, which is extremely difficult to manage. All right. So what makes sense is that once you get a clot, you keep it in place so that you can stop the bleeding. Now, this is the plasminogen. It's transferred into plasmin through tissue plasminogen activator and urinary plasminogen activator. As you can see, the tissue plasminogen activator is released with trauma or with hypoxia or more damage. So what happens is that with the more damage, the more hemorrhage, the more activator, it becomes hell. It becomes hell. And these are the patients who take a lot of blood, and blood gets more blood, and so on and so on. So if we can take this out of the equation, the plasminogen to the plasmin, then we can keep our blood clots, and what we give later on for the coagulation system will still work. All right. I have not consumed everything. This is a schematic diagram. Now, what will happen here, the tranexamic acid will bind to a site in the plasminogen, which prevents it from acting on fibrin in the lower part. Here, attack on the fibrin. We cannot destroy the fibrin. The fibrin is now immune from action here. Okay. Now, let's look at a few clinical scenarios, all right? Let's on with the blood bank and get more donors. We always have something we say in obstetrics, mild hemorrhage is overdiagnosed and severe hemorrhage is underdiagnosed. We are happy that we are overdiagnosing mild hemorrhage. Then we got a rapid response with a wide bore intravenous access. We oxygenate, we start massaging the uterus or compressing it. We send labs for coagulation defect because if the bleeding continues, we will get more and more damage to the fibrin degradation products, less and less fibrinogen, less and less. Then we start giving blood. We will give uterotonic drugs. Everything is okay, and you can combine. Oxytocin and carbitocin are redundant. One of them should be enough. Carbitocin, in my opinion, is better because a single dose occupies all the receptors. But in oxytocin, you have to maintain a drip. Misoprostol is good. Dinoprostone probably will be too weak to stop bleeding. So misoprostol will be better, and methyl ergonovin can be used. Then we have tranexamic acid, 1 to 4 grams intravenously initially, then 1 gram per hour for 3 hours. We stop after 3 hours. Why? Because we don't want thrombosis in other parts of the body. So what we do, we give 1 gram initially or more, then 1 gram every hour for a maximum of 3 hours. Does this work? After that, if we need, we do examination on anesthesia, a uterine tamponade, we prefer balloons. Some people use packs. Then we go for the very drastic surgery, compression sutures, devascularization, hysterectomy, and in severe cases, there's nothing we can do except pack the pelvis, which is damage limitation surgery. We hope nobody gets to that. Once everything starts bleeding and you cannot stop the bleeding, the coagulation system has totally failed, you're in damage limitation surgery mode. Okay? Now, does tranexamic acid work for postpartum hemorrhage? It probably could save 1/3 of deaths from postpartum hemorrhage, which is a huge number. In Egypt, hemorrhage, postpartum with antepartum are the main cause of maternal mortality. Postpartum alone is the second most common, because if we are going to divide postpartum and antepartum into separate categories, then preeclampsia and hypertensive disorders are number 1. So postpartum hemorrhage by itself is number 2. We can prevent deaths, 1/3 the deaths. But we have to go for the immediate treatment. An immediate treatment gives us a better survival by 70%. For every 15-minute delay, we have a 10% drop in the survival. Why? We have to stop the formation of the fibrin degradation products. We have to stop the clots from being dissolved. We need new clots to stop the new bleeders, not to all the time re-examine what we're doing. After 3 hours, it's useless. So we have to be minded. We can't wait for the help to tell us. So every single person must know this, okay? The WHO has listed tranexamic acid under the list of essential medicines. There are a group of essential medicines. That means they have to be present in all countries. So it's one of them. We should start early, and we now advocate using it for prophylaxis, and it can be part of the management of the 3rd stage of labor and can be part of the management of C-section. It can reduce the incidence and the mortality, and it can even reduce blood loss in C-section. We give it 1 gram over 10 minutes. For vaginal birth, we give it after cord clamping, but for C-section, the earlier, the better. Every 15 minutes, we lose 10% of our benefit. So we give it with the induction of anesthesia. It's a very safe drug, and it almost never harms the baby. The WHO now strongly recommends the early use for standard care. We use it for all cases of postpartum, regardless of the cause of the bleeding. The mechanism of the bleeding is irrelevant. If it's trauma, use it. Atony, use it. Coagulation disorder, use it. Retained placenta, use it. Okay. We give it within 3 hours to be effective. Now, let's look at the gynecological bleeding. So in obstetrics, we should more or less universally use it. In gynecology, abnormal uterine bleeding is divided according to FIGO into the PALM, COIN classification. PALM are structural or pathological causes: polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. These have definitive treatments. That means there is a treatment for fibroids, there is a treatment for adenomyosis, there is a treatment for malignancy. Here, we do not have structural pathology. C is coagulopathy, O is ovulatory dysfunction, what we used to call dysfunctional uterine bleeding. We no longer use the term dysfunctional uterine bleeding because it has a non-specific meaning. We say abnormal uterine bleeding due to ovulatory problems. Then we have endometrial. AUBE, endometrial, means a patient. These are extremely common patients. They come to the clinic, they say, I have heavy menstrual bleeding. Nothing is wrong with the ultrasound. There is no coagulopathy, but each single time she has. This is probably a local disorder of the endometrium. It is diagnosed by exclusion. If we find no cause, then we will call it AUBE, endometrium. Then we have AUBI, iatrogenic. The most common cause of iatrogenic is the IUD. especially the copper-containing IUDs. These are, the bleeding is almost invariable, almost to various degrees. We have uterine niches, can cause IUBI. Irregular use of hormones can cause AUBI, and injectable contraception can do the same. They're not yet classified. All right, now in a Cochrane review, antifibrinolytic medication, the heavy menstrual bleeding, can reduce the bleeding by 40 to 50%. If we reduce the bleeding by 40 to 50%, a huge number of patients will be spared surgical interference, all right? They will be spared other therapy. In fact, one of my colleagues who loves doing hysterectomies say, I never give it because I want to keep on doing hysterectomies, all right? That is ridiculous, but it is true. So we have to understand that it can reduce the bleeding, okay? It's better and improving than other medical treatments except for the LNG IUD, the Mirena. This is the only thing which works better. To be honest, also the Dienogest containing pills work very well, okay? But it doesn't have to be either or, we can use them in tandem, okay? It will improve the quality of life. So let's look at acute AUB. A patient has called you and said, I have severe hemorrhage, and it is not an abortion. What we will do, we can do it outpatient or inpatient. If we're going to do it inpatient, it's really heavy. We give intravenous tranexamic acid. If we're going to do it outpatient, we also give tranexamic acid. This is the main. We can add hormonal therapy, all right? It does not preclude the use of hormonal therapy. In fact, the contraindications to hormonal therapy are huge. The contraindications to tranexamic acid are almost non-existent. There are a few contraindications, but they are very few. Now, if we fail, we go for the procedural management. If we look at the procedural management, we have intrauterine Foley catheter. She has to be in hospital, and it's a very painful condition. Hysteroscopy and curettage, uterine artery occlusion, endometrial ablation, hysterectomy. If you tell the patient to choose, she will definitely not like this. All right? So if we can get a good result with medical therapy, which has few or minimum side effects, we should be much better off. So this is acute. A patient has called up, say, I have a huge amount of blood. I cannot leave the toilet from the severe bleeding. All right, let's look at chronic IUB. Chronic, that means it occurs in every cycle. Antifibrinolytic drugs will work, and they reduce bleeding by 30 to 55%. Now let's look at category. AUB pathology. That means AUB due to polyp, or due to fibroids, or due to adenomyosis, or due to malignancy. We're not going to talk about malignancy, it has to be treated, but it can reduce the bleeding with fibroids. In fact, it can be given before the operation to reduce bleeding in myomectomy, and it can even induce necrosis in a fibroid, which is logical, because if I have a clot inside the vessel inside the fibroid, and I keep this clot in place, that means part of the fibroid will die. So the fibroid can shrink in size, because we will prevent the continuous recanalization of the vessels inside the fibroid. So a patient can use it along with other therapy if she wants, if she doesn't want an operation, and she can improve. So patients who have fibroids, who do not want surgery, it's a good option. It can even work in adenomyosis for the bleeding, but not for the pain. So a patient with adenomyosis who doesn't want therapy, doesn't want definitive surgery, we can give her non-steroidal anti-inflammatory drugs for the pain and tranexamic acid for the bleeding, all right? This is the best therapy except for the LNG-IUS, right? The LNG-IUS. Okay, now let's look at one of the most tricky AUBs to treat, AUB-C, AUB coagulopathy. AUB coagulopathy is extremely hard to treat. In fact, in uterine artery embolization, they hate doing these patients because they don't improve. All right? So some procedural therapy for patients with coagulopathy doesn't work. The patient has severe anemia, severe hemorrhage, Every single time she gets a period, it's an adventure. All right. The patient is usually young. She can be in university. She can have purpura, whatever. Okay. So the non-hormonal therapy, we have tranexamic acid in a higher dose, 4 times a day. Hormonal therapy, we can give COCs or LNG, but a lot of these patients are young patients. So if we can control it with tranexamic acid, it will be most welcome. All right. Now, do we like hormonal therapy in patients who are on anticoagulants? Probably not, because hormonal therapy in a patient on anticoagulants, she's on anticoagulants because she's at risk of thrombosis, and we don't like giving pills to patients with a risk of thrombosis. So AUBC, okay. So I've done the PALM, all the organic, it will improve the organic, especially fibroids and adenomyosis. Polyps and malignancies should be treated. It can work with coagulopathies. Then we go for the AUBO. The patient has irregular cycles. She has a cycle every 6, 8, 10 weeks, which is heavy. Here we usually give progesterone therapy, all right? But we can still add tranexamic acid. It will help. They are used for the patients if they don't want hormonal therapy or if they want to use it as an adjuvant to hormonal therapy. A patient with polycystic ovarian syndrome, she has a lot of hirsutis and heavy periods. Okay, she can use it. Okay. Then we have AUBE, AUB endometrium. These are notoriously difficult to treat with hormones because her cycles are regular. She just has a lot of bleeding with each cycle. All right. It's probably a disorder in the prostaglandins and the vasoactive agents inside the endometrium. So what we do is we inhibit prostaglandins with non-steroidal anti-inflammatory, and we keep the blood clots in place with tranexamic acid and less commonly hormonal therapy. Because are we going to give hormonal therapy for life? It's hard. It's not that easy. So a patient who has heavy menstrual bleeding with no pathology or AUBE should be given tranexamic acid. Let's look at AUBI, iatrogenic. She is using an IUD. She has irregular bleeding with the hormones. All right. So she's probably having an IUD and she doesn't want to use hormones with the IUD. Or we could remove the IUD and just go for the pills, right? So it makes sense for us to give it for patients who are IUD users, especially if it's a copper-containing IUD. So AUB treatment, Paul, we treat the structural problems, but we can add other agents. AUBC, we talked about it. We can give either hormonal suppression or tranexamic acid. AUBO and E, we can give amyrina is the strongest. Oral progesterone is okay. COCs is okay. Non-steroidal okay. But the one with the least side effects is tranexamic acid. IUI, we can also use it with fibroids. Okay, now this is the nice guidelines for bleeding. As you can see here, a patient who doesn't want LNG-IOS, we give TXA. A patient who wants it but has other problems, also TXA. Patients even with organic pathology as fibroids will also use TXA. All right, so we have to add it to our armamentarium in patients with bleeding, probably regardless of the cause of the bleeding. Okay, thank you very much.
Thank you, Dr. Ayman, for this very interesting lecture. And لو في أي question, Dr. Ayman, اتفضل.
AUBE, dose of oral tranexamic acid, and for how long?
Yeah, okay. For oral tranexamic acid, we usually give 1 gram, 2 tablets, 3 or 4 times a day. That is generally the treatment in all oral cases, okay? Throughout the period of main bleeding. If she says, I have heavy bleeding the first 2 days, then make it the first 2 days. If I have a heavy bleeding throughout, we can make it throughout. The side effects are almost non-existent. In fact, the patients know it. And they start after the first few times, they start taking it by themselves. Yeah. Yes, please. I'm sorry, but my voice is hoarse.
ايمن هاني استاذ مساعد في وحده الحمل الحرج في القصر العيني.
اهلا بحضرتك.
محاضره جميله جدا جدا جدا. بس احنا بيقابلنا في عيانينا بتوع الحمل الحرج الناس اللي عاملين او دبل فالف ريبليسمنتس وماشيين على ماريبان with high doses.
Excellent.
فهو العيانين دول احنا اغلب الحالات دول بنركب لهم المايرينا فور كونترسبشن، وده اللي بيريجوليت السايكلز، بس بعضهم بيحصل له اكسبالشن للمايرينا او كده، فبيبقى عندهم مشكله من الهيفي سايكلز، والدكاتره بتوع الكارديولوجي بيرفضوا خالص موضوع
You're right.
Tranexamic اكسترا.
Yes.
في العيانين دول لما بيجي لهم اتاكس اوف بليدنج احنا بنبقى يعني ان هايلي كومبليكيتد تايم نضطر نعمل ادميشن للعيانين دول. فانا كنت عايز اعرف وجهه نظر حضرتك نمشي ازاي.
This is an excellent question. Patients who are anticoagulated. The anticoagulated patients, especially the warfarin patients, okay? Because the patients who are anticoagulation on direct anticoagulants, they are short-acting drugs. So what happens is if the patient is on rivaroxaban or apixaban, she can stop the drug on the first couple of days and it will work because they are rapidly acting, rapidly eliminating. The patients on warfarin are usually one of three. Patients who have high-risk heart valves or replacement, or patients who have antiphospholipid syndrome because the other don't work, or patients who are breastfeeding. Those three patients are the patients who are on warfarin, okay? Patients who are breastfeeding, we can give it in breastfeeding if we really need it. There's no problems, okay? Patients who are antiphospholipid syndrome. Now, what's the problem with the patients? Why are they on heart valve medication? Is it because we want the clots to dissolve? Or is it because we don't want clots to form on the valves, right? It's because we don't want clots to form on the valve. So if she has really heavy bleeding, instead of stopping the warfarin for a few days, it makes sense to give this for 1 or 2 days, all right? Because the alternative is stopping warfarin for a few days, right? The problem with stopping warfarin takes 5 days for its action to stop and start. So what happens? The patient has a period. She stops the warfarin. She keeps on bleeding for 5 days. Okay? After the 5 days are over, she restarts the warfarin. She gets thrombosis because the warfarin has not yet acted. All right? So the problem with warfarin, the start and stop with warfarin is terrible. The start and stop with warfarin is terrible. Warfarin has another problem. The patient has eaten a lot of vitamin K. The warfarin loses its action. So we have to have a diet which is more or less fixed. Because what warfarin does, it prevents reformation of vitamin K from vitamin K etopoxide. So if I give a lot of vitamin K, warfarin doesn't work. Okay? So that's the thing about, because it prevents the recycling. So if I give a lot, that's why the antagonist to warfarin is vitamin K, all right? So that's the thing with it. So if you have to give it, the bleeding takes precedence over the risk of thrombosis because the bleeding is real. The risk of thrombosis is supposed, all right? So we have a lot of patients, heart valve, anticoagulation, who have placenta accretus, terrible. We have to put IVC filters, all right? So it's hard. If you can put an LNG IUS on the long term, would be very good. Implanon is going to be available in a few months. You can give that also, all right? We don't like intramuscular progesterone. They can cause abscesses. But the subcutaneous, if it comes back, we can give the subcutaneous too. So I would go for LNG IUS, subcutaneous, Depo-Provera, and we can give in the acute attacks, we can give that. Okay. Yes. Yes, normal delivery after cord clamping. Yes, that's an excellent question. A normal delivery is not going to start to bleed until the placenta is delivered, right? So I don't have to do it quickly. But the C-section is going to start to bleed as soon as I put in the scalpel, right? Okay, so that's the thing about it, all right? So when she's going to start to bleed, we have to be ready, all right? Because if I'm going to wait, the patient has already started to bleed and stuff like that, all right? But if you want to give it in cesarean section after delivery of the baby or clamping of the cord, okay, it gives better results if it's earlier, that's all. Yes, please. Yeah, patients with history of DVT or pulmonary embolism. All right, I said there are a few contraindications. These are one of them. But we have to balance benefit and risk. We can't let the patient bleed to death, all right? So the alternative is what? The alternative is stopping the anticoagulant, right? Until the bleeding stops. That's what we do in our university. Or we give plasma, which has new coagulation factors. It doesn't make sense. So if I have to give it for 1 or 2 days, it makes more sense than stop and starting anticoagulation, especially if she's on warfarin. If she were on an oral, a direct anticoagulant like as rivaroxaban or apixaban, what I would do, as soon as you get your period, you stop for 1 or 2 days, okay? And keep yourself well hydrated and stuff like that. And then as soon as the bleeding tempers off a little bit, go back, okay? Those are the patients on the direct or anticoagulants. But the patients on warfarin are extremely difficult to manage. Yes, please. Could we have a mic over there because I can't hear? I think a lot of us are already using it. So what we're doing, just expanding it a little more and giving it credence, all right? Because the WHO has put it on the list. Yeah, please. You have a mic there?
نشكر سيادتك على المحاضرة القيمة جدا دي واللي هي مهمة جدا جدا في حياتنا. سؤالي احنا دلوقتي بنقول في البريجنانسي بيكون في هايبر كواجابيليتي.
صح.
تمام؟ طيب انا لما ادي ترانساميك اسيد بري اوبراتيف مثلا في السي اس او بعد كلامبنج اوف ذا كورد في النورمال ديليفري، هل ده بيساعد على ثرومباي في
Yes, we hope it does. We hope it does because we are now doing a C-section, right? We want the coagulation system to be ship-shape because in pregnancy, we have 2 things which are working. We have enhanced coagulation system and a hyperactive plasminogen system. All right? Both are working too hard. Okay? So the plasminogen is good to prevent thrombosis. But right now, I'm an operating, right? And I'm operating on an organ which is extremely vascular. Right? Okay, so what we do is that even the patients who are on heart valve, we have to stop the anticoagulation before the operation. Right? We hate working on patients who are on anticoagulants. All right. So what happens is that it's just for temporary, and then it works just for a short time. And it works not by causing thrombosis, because it doesn't. It just, the vessels who are already thrombosed, it stops them from rebleeding again. You understand? Okay. So we are not actually causing the thrombosis. We are just preventing the bleeding from the vessels who have already clotted and stopped bleeding. Okay. And these are data. The WHO does not give a guideline easily. They lag behind. All right. So when they get to that, it's really hard. Okay. Maximum allowed dose is 3 hours. 1 to 4 grams initially, then 1 gram every hour for a maximum of 3 hours. That's all. You cannot give it after that. Yeah, ethamsilate is not like it's not like this. It works another way. It can be used, but it's not that active. The one that's like this is aminocaproic acid. All right, aminocaproic acid is like this a little bit. Okay, so it's different. It does not have a strong mechanism of action. So what we do for ethamsilate is that if a patient is not responding to this, she can add it. All right, or she can switch it. But this takes the first. This is part of the guidelines. Okay. Yeah, patients who are on Marivan, that's good. Because ethamsilate works mainly on the veins, improves venous tone. If you want to use them, use them. I don't think they really work, but I have no problems if you want to use them. Okay. Okay, thank you very much. Thank you very much, Mr. Chairman. Thank you.